Hi, my name is Dr. Daniel An. I'm one of the GI medical oncologists here at Mayo Clinic, Arizona, and this is my colleague, Dr. Bekaii-Saab, who is also a professor and a medical oncologist in GI malignancies. And here we're just going to provide a brief update about what's going on in 2017 and future directions going forward. So recently at our ASCO GI 2017 symposium, we've seen a lot of interesting data, mainly in the area of immunotherapy. And this has been kind of a hot topic, and not only in GI cancers, but all solid tumor malignancies. Mainly, most of the data that's been matured is mainly in thoracic malignancies, as well as renal cell and melanoma. But recent publications and abstracts that were presented suggest that immunotherapy may also play a role in GI malignancies, mainly in gastric cancer and hepatocellular cancer. The data suggests that even patients that were treated with multiple lines of that were refractory to standard chemotherapy still received a survival benefit from immunotherapy. And so the question going forward is, can we improve patient outcomes if we use these lines of therapy to the earlier line settings? We do have a study going on with our colleagues at Mayo Clinic Rochester where we're looking at the role of immunotherapy in the earlier line settings, mainly for patients before they go to surgery. And so there's a lot of interest in that. Here at the Mayo Clinic Arizona, we do have a study that's looking at the first-line therapy for immunotherapy and hepatocellular carcinoma, so the primary tumors that do arise in the liver. And Dr. Bekaii-Saab can talk a little bit about how this role plays in colorectal cancer as well.
So thank you, Daniel. I mean, this is a very interesting time. Immune therapies are becoming a standard across multiple cancers. I mean, this is a different world today than the world I trained in many years ago, where chemotherapy was our only standard. So we're able to unleash the power of the immune system to attack various cancers. So Dr. An talked about gastric cancers and talked about liver cancers, where we're seeing these modalities move in. Colon cancer for quite a while now has been looking very promising in terms of developing these immune therapy agents into the field. One of the most interesting areas is actually those tumors that are considered MSI high or microsatellite unstable. 4% of patients with stage 4 colon cancer, we had a lot of experience with this group, and we continue to develop these modalities in clinical trials at Mayo and elsewhere. But these are patients who essentially have a significant response to immune therapies, including complete remissions in some. And traditionally, those tumors that express these proteins or miss those proteins, so they're unstable, they don't respond too well to chemotherapy. And the more interesting part is now taking those advantages in the more refractory cancers to the first line, meaning we're trying to move this up front. Patients who first get their diagnosis, rather than put them on chemotherapy and wait for chemotherapy to fail before we introduce immune therapies, we're moving those up the line. Another area of interest is a study that's led by actually Mayo Clinic investigators across the whole nation, which is looking at moving these inhibitors, these immune therapy agents, into the earlier stages of cancer, stage 3, to see if we can bring the cure rate from close to 70–80% to almost 100% in that group of patients that essentially has these MSI high tumors. In the earlier stages, we find them in 18% of the patients. Then there is another group of patients, the 96% with stage 4 cancer, who are essentially microsatellite stable, so they don't have the mismatch repair protein, so they are actually proficient. Those are 96% of the patients. They don't have options like the other 4% in terms of benefiting from immune therapies. They do well with chemo. They do very well with chemo, but we always eventually end up running out of chemotherapy options, and the question is, can we bring immunotherapy into this group? Number of strategies are being developed in that stage. Some of them are spearheaded by our Mayo colleagues, including Dr. An and myself, and others are being spearheaded by other institutions that we work with closely. So this whole modality of immune therapy is moving very fast in the field of gastrointestinal oncology. So outside immunotherapies, there's also a lot of agents that are being developed. Those agents we call targeted agents, tyrosine kinase inhibitors, with various names, mostly oral agents that have specific targets on the tumor. And there's also a lot of new updates coming from our recent meeting and others regarding the role of an agent called regorafenib in gastric cancer and stomach cancer and liver cancer as well.
Yeah, so as Dr. Bekaii-Saab mentioned, regorafenib is a multi-targeted tyrosine kinase inhibitor that blocks a lot of these signaling pathways that cause cancer cells to grow in the first place. And this drug actually has been approved for several indications, and it looks like it actually may be more interesting than we thought for other malignancies, including hepatocellular carcinoma, based off a recent phase 3 trial that was presented. The study suggests that patients actually have an improved overall survival compared to the previous standard of care, which was sorafenib. And so the question is, do patients potentially may benefit from this if we move it up earlier? And that question is still up for debate. The other area where this drug looks really interesting is in gastric cancer, where they showed that patients that received this drug, despite failing multiple lines of chemotherapy, also received a benefit in what we call their progression-free survival and overall survival. However, one of the main areas or obstacles that we need to overcome is the optimal dosing of this medication, which Dr. Bekaii-Saab can kind of discuss a little bit more.
Yeah, so this agent, like a lot of these oral agents, can have their challenges. Some patients have almost no toxicities. Others have really a real difficult time to go through the higher dosages of the drug. The majority of the patients will find their way into a dose that's a little bit lower, but yet effective. So Dr. An mentioned gastric cancer. This is moving forward into phase 3 in gastric cancer. Mayo Clinic is also leading the charge, and at least the Mayo Clinic network is leading the charge in working, and Dr. An is one of the investigators on that trial. But the dose, as mentioned, is a challenge, and we actually have a study that's about to complete, and we're hoping to present the results later this year. It's in colorectal cancer, but it's applicable to all cancers in terms of the dosing strategy. What we're trying to understand, should we start all the patients at that maximal dose of 160, or can we actually find a strategy where we escalate the dose from 80 to 120 to 160 over a period of 3 to 4 weeks and get the same results, yet find those patients that are less likely to tolerate the higher doses and put them at the right dose and still produce the same benefits. And these results, once presented, will apply not just to colon cancer, but to gastric cancer and liver cancer and anywhere else where this agent and perhaps other agents as well may apply.
In pancreas cancer, there's also been a lot of development, mainly in the area of what we call adjuvant therapy, meaning in patients who have undergone surgery, do they benefit from any further chemotherapy? Over the past decade, the established standard of care essentially has been gemcitabine, which is a drug that's not only used in the early setting, but in the advanced setting. But recent study results from mainly the study called SPAC4 showed a benefit of the addition of capecitabine, or also known as Xeloda, in combination with gemcitabine. And it showed not only a progression-free survival, but an overall survival for this drug. Now based on the results of this study, we're seeing patients with early pancreas cancer have undergone surgery to live almost a third of them have lived at least 5 years, which is unprecedented in this disease. And Dr. Saab can talk about whether or not there's any other new interesting developments in the setting of not only early, but mainly in the advanced setting.
Yeah, so as you know, in the adjuvant setting, so following surgery, there's also another trial that's complete, and we're waiting on the results with gemcitabine and nab-paclitaxel, or commercially known as Abraxane. And the results of that will come later this year. So we may actually have more additions to the armamentarium in treating the later stages, the earlier stages of the disease following surgery. But in the later stages, there are some developments. You know, this has remained a challenging setting, but I think we've been doing strides one step at a time. We're almost about close to double the 5-year survival for all the patients with pancreas cancer. We're going to start hitting the double digits, which is quite significant in a disease that has persistently remained in the single digits for so many years. Some of the most interesting targets in development in pancreas cancer are essentially inhibitors of stem cells. There's an agent called BBI-608, which is undergoing now development and moving to a phase 3 study based on some really promising early results. This is now the phase 3, 1,200 patients actually running throughout the world, and we are taking a big lead into developing and helping run this study. The other agent in development is a drug called PEG-PH20, which essentially just mostly works around this packed platform around the cancer cells, and essentially helps dissolve some of the scarring that occurs around the cancer cells and allows the flow of chemotherapy, at least theoretically. So the study is selecting for the protein that's being targeted by the agent, and that's a phase 3 study that's under development. The third target, I think, one of the most interesting targets, although it's limited to about 10% of patients with pancreas cancer, is pancreas cancer that is linked to BRCA. Not just in the genetics of the patient, and a lot of patients, 2 to 3% of the patients will have that mutation inherited from their parents or from their grandparents, and essentially it increases the risk of breast cancer as well as pancreas cancer and other cancers. So we can take advantage of that mutation, and for those cancers that essentially are driven through that mutation, we have agents called PARP inhibitors in development in combination with chemotherapy as well. We have a study that essentially is looking at one specifically interesting PARP inhibitor called rucaparib in combination with an agent called MM398, or commercially known as Onivyde, used already in clinical practice to maximize the level of synergy in these patients. There's also, interestingly, about 8% of the patients that will have their pancreas tumors having acquired this mutation, BRCA or PALB, and those are also targeted in that study and with this group of agents. And then we think there's about another 10 to 15%, so 1 out of every 4 patients, when you add the BRCA and what we call the BRCA-NES, that may essentially have some derangement in their cancer cells that will make them susceptible to agents like rucaparib. And those will be included as well in the study. So we may be able to target 20 to 25% of all patients with pancreas cancer with this group of agents. So a lot of good development happening across multiple GI malignancies in pancreas and colorectal and gastric and liver cancer, neuroendocrine. A lot of exciting time actually to move the needle forward, where hopefully, across multiple malignancies, we're going to continue improving the survival of our patients.